So, good morning, everyone. Thanks for having me here today. I'm Eli Kern, an epidemiologist with the Public Health Department in Seattle in King County, as Leah mentioned. And I've been working with a team with health insurance claims data for the past several years. And for the past year, we've been working with the All-Payer Claims Database, which is a relatively new resource in Washington State that was stood up through some Affordable Care Act-related funding and local funding as well. And today, I'd like to sort of share some of our team's work and lessons learned in trying to use this database for accountable communities of health. And there are 5 accountable communities of health that we've been contracted to provide data and analytics services to over the past year. For today's presentation, where possible, I included sort of North Sound ACH region-specific data. And where I wasn't able to do that, I'll sort of try to comment on the reasons why. Throughout the slide deck, there will be some points where I have questions for the audience. And so as Leah mentioned, I think what would make sense is to post your questions to the chat box, and I should be able to see them, or if not, Leah or Nika will let me know. All right, I'm going to get started. So first, a little bit of background on the All-Payer Claims Database, or the APCD, as we call it. So it's the state's most complete source of health and dental insurance data. There are many other states, but not all in the nation, that have a mandatory or voluntary APCD. Mandatory APCDs are databases where everyone or a certain subset of health insurance companies are required to submit health insurance claims information. Voluntary is, as you might guess, is an arrangement where people can submit, or organizations, companies can submit if they want to. Before the All-Payer Claims Database came into existence a couple of years ago in our state, there was a voluntary all-payer or voluntary multi-payer claims database run by the Washington Health Alliance, and they still maintain that database. And so it's not that there's only this source of information. However, this all-payer claims database is the first sort of multi-payer sort of source of claims data that had wide access offered. So a variety of entities could pay or gain access to the data in a variety of ways. The database itself contains claims from more than 55 health plans when I last checked, and this includes commercial health care payers, Medicaid, including the 5 managed care plans that operate in Washington State, Medicare, both Medicare Advantage, which is the managed care equivalent of Medicare, and the fee-for-service side, which is run by the federal government, the Centers for Medicare and Medicaid Services. And then dental claims as well, including Delta Dental. The All-Payer Claims Database has historical data going back to 2014, and this is actually a little outdated. It goes through 2018 now. And it's updated each calendar quarter. And in each quarter, the most current claims are added to the all-payer data set. Currently, or last at least that was updated on the database's website, it holds information on almost 5 million Washington residents. In terms of coverage, I couldn't find updated statistics on this, and it might vary by county and region, but for Medicaid, we can sort of rest assured that it has the entire market, meaning all Medicaid members, because it has the healthcare authorities data, which is the fee-for-service side, and then all of the managed care organizations. For Medicare, it should have the full market now because it has Medicare Advantage. Maybe there might be some plans that aren't in there, and it now has the national fee-for-service data, which is the vast majority of Medicare claims. For commercial, when I last sort of queried the organization that coordinates the database last fall, they had about half of the market is what they estimated statewide. And the reason for that I'll get to on the next slide. It opened its doors for business in terms of data products, access to raw data last July. And that's, as I mentioned, we've been working with it for a little over a year. And there is a public-facing website with a link there on the slide that has a variety of tools on there, including an ability for consumers to look up the average cost of a service, like an emergency department visit. To date, the key players in operating this database have been the Office of Financial Management and the Governor's Office. They were charged with establishing and overseeing it, but that role is transitioning to the Healthcare Authority. This was actually changed in the last legislative session, so transitioning to the Healthcare Authority this year, and Healthcare Authority should be in place to coordinate the all-payer claims database beginning in January of 2020. The lead organization, which is the organization that sort of coordinates and manages the database and sets the policies around access and use, has been Oregon Health Sciences University until June of this year. And moving forward, a new lead organization will be selected, but I have not heard who it will be. And then finally, there is a vendor that actually builds the infrastructure for the database and receives the quarterly data from the 55 plans, cleans it, normalizes it, and updates the database. And that has been On Point Health, and they're a data vendor in the state of Maine, and they've actually set up all-payer claims databases for many other states, I think including Vermont. So as I mentioned in the last slide, the database it has a lot of coverage, but it's not complete. And the reason is because of the legislative structure of the sort of mixed mandatory and voluntary nature of the database. So on the left-hand side here in blue, we see the payers that are required to submit data quarterly, and those are Medicaid, which is why we have 100% of the market, all Medicare Advantage and Medicare Part D, which is pharmacy coverage, the Public Employees Benefits Bureau, commercial insurers who sell plans on the health benefit exchange, and workers' comp, so labor and industries. On the right, though, are a long list of health insurance payers that are not required to submit but can voluntarily submit their data. And the most important here, I believe, in terms of where we are now in coverage, is that first list, which is self-funded employer-sponsored plans and health trusts. And that's all the big companies like Amazon and Boeing and King County, where I work, who own their own health insurance data, and they usually contract with an entity like Kaiser or Regents to sort of administer their plan, but they're not a plan that's being sold, or they're not using a plan that's being sold on the health benefit exchange. So they can choose whether or not to submit. Medicare fee-for-service federally also can choose, but luckily they have been agreeing to submit. Standalone dental plans like Delta Dental can also voluntarily choose whether or not to submit. Luckily, Delta Dental has been. Indian Health Services, another critical source of information, is not submitting information to the all-payer claims database as far as I know. And Veterans Affairs and military claims not being submitted. And then there's a variety of ways for health insurance companies to get waivers, extensions, exceptions, and things like that. Going on to the next slide. So what is included in the all-payer claims database? And I wrote up here Analytic Enclave. This is one product that they sort of offer, which is a sort of virtual workspace environment through which you can access sort of more or less the raw data as it's submitted, as well as some cleaned up data tables. And that's what we've used most for the past year to try to answer a variety of questions that are meaningful to the ACHs that we serve. So what's included over on the left in blue is paid claims. The qualifier there is because some health insurance claims are denied, right? And then maybe a provider or a biller sort of resubmits again. And because of that, there can be a lot of duplication and noise that's in claims data. And so the all-payer claims database only has paid claims. And in these categories, medical, mainly physical and mental health, and I'll comment on the mental health in a moment, pharmacy data, and dental data. It also has member eligibility info, such as where people live for a given time period, their age, their gender, very limited race and ethnicity information, which we've been doing a lot of education advocacy about, which I'll mention more later on, and other information about the type of coverage they have. What's not included is denied or otherwise unpaid claims, claims for substance use disorder services, and I believe also many mental health services. I'll comment more on that later. And then, as I mentioned, some demographics like race and ethnicity and language are included or not included, but right now they've been largely unusable, and I'll mention more why later on in the presentation. In terms of timeliness of the data, as I mentioned, the data goes back to 2014. Payers, so health insurance companies, submit the most recent 3 months of paid claims about 30 days after each quarter ends. And so the claims paid in a given quarter may be for dates of service in that quarter or prior one. So it's a rolling sort of refresh of information because claims lag, meaning that it takes time. It can take time for providers to submit claims, particularly medical claims, and within that particularly things like hospital claims or skilled nursing facility claims. It takes time for all the claims to come into a company, to a health insurance company, and then for those to go forward to the all-payer claims database. Then the vendor, OnPoint, takes some time to process that data and get it into the database. They report it takes about 2 to 3 months, but actually I think they've been doing it much faster than that. So all in the end, what we're left with is a data set that typically takes about 9 to 12 months to be complete. We're actually investigating whether that's really true right now. It is true from a paid perspective. So if you want to wait to see the final paid amount, which is one crucial source of information that's in this database, then you probably do have to wait that long. Whether you have to wait that long to look at other things that aren't related to payment, like how many emergency department visits there are or how many primary care visits there are, that remains to be seen. And the vendor is doing an analysis right now for us to sort of help answer that question. So before we get to the actual data and findings, sort of one last slide about, well, what questions could we answer or could ACHs answer using these data? So on the left here in blue, here are some questions that have come up in our conversations with our ACH partners. Things like, are there zip code level disparities in diabetes diagnosis or diabetes prevalence in my region? And I'll show a North Sound specific map on that later. Is performance on all-cause hospital readmissions improving for a given focus population? So all-cause hospital readmissions is as many of you might be aware of, I'm not sure what's been covered on past webinars, is a performance measure for the Medicaid transformation. And so there's a question about, well, since we're choosing to focus maybe on this measure through this strategy, is there any change in this measure? And so the data can be used to look at that. Again, keeping in mind that there's that 9 to 12 month lag. Another question, which providers tend to serve the types of individuals that the ACH has prioritized for a given strategy like chronic disease management? Another question, what's the variation in Medicaid volume, meaning number of people on Medicaid, among providers in my region? How does the Medicaid rate of emergency department visits compare to the commercial rate, commercially insured rate? And then questions about cost as well. What is the average cost of an ED visit across hospitals, for example, or across demographic groups like age groups? What it can't answer, and I have in parentheses yet, because obviously it's a dynamic sort of system, and so some of these questions will be able to be answered someday. The first one is, are there racial ethnic disparities in diabetes diagnosis in my region? And the reason that I don't believe we can answer this yet is because the quality of the data is poor, and there's a very specific reason for this. When the database opened its doors, they created a manual that for all those health insurance companies to tell them what data elements had to be submitted, what were required. And for whatever reason, in that initial manual, only a single race data element was requested. Now, we know in King County, through working with Medicaid claims data outside of this database, as well as many other data sources, that a single race category is insufficient because many individuals, particularly in urban areas, identify with more than one race and or ethnicity. And so we dug into this more in terms of why was this set this way, and found that the reason is that many commercial health plans don't even collect race and ethnicity. And so because the sort of lead organization sort of interpreted that the quality of the data would be so low, the missingness would be so high, that they just said, well, let's ask for just a single race variable if insurance companies have it. But the problem with that is that there are insurance companies or there are organizations like the Healthcare Authority that have more than one race variable. The Healthcare Authority actually maintains 4. And so the way that a single one was chosen was kind of random. I mean, the manual says, please choose the primary race, but the concept of primary race doesn't even make sense for most individuals, and certainly wasn't how the data is organized. So we've done a lot of education and advocacy with various stakeholders around getting more race information into this database because we feel it's crucial for equity work. We just learned actually last week that a second race and ethnicity variable will be added. That's progress, but still insufficient in our minds. So we'll be continuing to do further education work around this topic, trying to get all race ethnicity variables as well as language variables into this data so that we can do proper equity analysis. Another question that can't be answered is, has primary care utilization improved among members with a mental health or substance use disorder diagnosis? And the reason is because many mental health services, particularly substance use services, are not captured. And the reason for this is that is federal law. So I'm sure many folks have heard of HIPAA, and HIPAA covers protected health information as well as many other things. But identifiable chemical dependency or substance use disorder treatment data is covered by a separate federal law, 42 CFR Part 2, which requires individual consent of a patient for their identifiable substance use disorder treatment information to be shared with anyone. And because of that, when this database was set up in the state of Washington, there was a decision made to have essentially all behavioral health treatment services censored, so removed from the claims that are being sent to the APCD. Now, we've been doing analyses to see has that really been happening, what level of information is missing. I'll show a slide later on depression prevalence, and there is plenty still of mental health diagnosis information in the data, and it's because it comes through in medical claims. But it does look like through some provider organization level analysis that we've been doing with North Central ACH, that the vast majority of claims for behavioral health agencies are not being submitted to this. And so because of that, we have an underrepresentation, underestimation of both need and treatment. And so we can't really, I believe, yet ask meaningful questions around behavioral health. Another question we can't answer yet is how many ED visits occurred last month? And the reason is because of that data lag. Similarly, what services did my client receive last week? So the reason I have these on here is because understandably, when the database opened, these were some of the most frequently sort of asked questions we were hearing in terms of using this data for care coordination or for clinical quality improvement. And it's too lagged, I think, to really support those use cases so far. I'm going to skip over most of this lower thing, except there is one thing I want to mention at the very bottom, which is when we talk about providers, healthcare providers, some definitions might be helpful. So within the language of the APCD, there are these three levels. There's what they call the rendering provider organization, which, HealthPoint is an example of that. HealthPoint is a network of federally qualified health centers that operates in King County and beyond. They also then have the concept of a rendering clinic practice location, which would be a brick and mortar location where services are provided. So for this example, the HealthPoint Redmond Clinic. And then there's the concept of a rendering provider, which would be, using myself as an example, nurse practitioner Eli Kern working at HealthPoint Redmond. For the way that we got access to this data, we agreed to do analyses at that provider organization level and the clinic practice location level, but not looking at individual people, individual providers. Okay, so now I'm going to get into what we've been doing to use the data to support ACHs. Just going to check, hold on a second. Any questions coming in so far? No? Okay, just want to make sure. Okay, stop me anytime, Leo or Nika, if there are.
Okay, no questions.
Okay, great. All right, so there'll be more coming now because I've got some prompts to ask folks why they think we're seeing the things we see. Okay, so here we go. So the first thing that we did with the data is try to understand both so that we could validate the data, because we had other sources of Medicaid data, but also just to look across the state to understand the Medicaid population. So who are Medicaid members? So here's an example of one analysis we did early on. On the left, we see for North Sound ACH regions, these are for people living in North Sound ACH, who had at least 1 day of Medicaid coverage between June 2016 and May 2017, we can see the age breakdown and the gender breakdown for these individuals. On the right-hand side is a subset of Medicaid members in North Sound. And the subset is that we've removed people who have 5 or more months of eligibility for Medicare or commercial. The reason for that is that this is the way the state is officially subsetting the data being used to calculate performance measures for your region and for every ACH region. And the reason behind that is that the healthcare authority has blind spots in terms of their data that they see. They have Medicaid data. They don't have Medicare data. They don't have commercial insurance data. And the reason that's problematic is because there's a hierarchy, and maybe I'm speaking to the choir, I'm preaching to the choir rather, because you probably know all this much more than me, but there's a hierarchy in terms of how health insurance types pay for services. So commercial plans pay first. If someone has multiple sources of coverage, commercial insurers have to pay first. then then Medicare, the federal government would pay, or a Medicare Advantage plan. Then Medicaid would pay, and then if a person has Indian Health Services coverage, Indian Health Services is actually the payer of last resort. So the reason that's important is imagine you're someone who has Medicare and Medicaid coverage, so you're considered a dual eligible, and you have an emergency department visit, and the hospital sends the bill to Medicare. Medicare would pay for some or all of that, and if they don't pay for all of it, they would forward it to the secondary payer, which is Medicaid in this case. Maybe Medicaid would pay just the coinsurance or the copay. And thus, what Medicaid, meaning the healthcare authority, would have in their database is just the information about how much they paid for the copay or coinsurance. But the problem actually is in the situation where Medicare doesn't forward the claim at all. They pay for everything. And in that case, we wouldn't even know that ED visit occurred. And so for that reason, the healthcare authority officially for calculating performance for ACH regions excludes people with sort of too much Medicare, Medicaid dual coverage or too much commercial coverage or third-party liability coverage. And so on the right-hand side of this slide here, we see an attempt at sort of showing what happens when you remove people who have 5 or more months in a given year of Medicare or commercial coverage. And there's one of the big changes that happens down here in I've highlighted. And I wanted to sort of see if we can use the chat feature here to get participants' thoughts on why do you think this changes? Why did the percentage of Medicaid members in North Sound who are age 65 and over drop from almost 6% to 0.2%, so almost zero? Any ideas? Okay, so I see a response. I see multiple responses. Great. That's right. So this one wasn't too hard. It's because people who are age 65 or over are likely to be eligible for Medicare. People who aren't eligible for Medicare, it may be because of their immigrant or resident status, or they haven't worked enough for Social Security. They haven't worked enough, rather, in the country and paid enough taxes. So it's a very small proportion of people who are age 65 and over that actually remain. And so that, for us, was one of the initial lessons here with what these exclusions meant for the Medicaid transformation is we're really not talking about a population that includes older adults. And that's important to know for providers who serve older adults. It's not that this whole Medicaid transformation project doesn't value older adults. It's just that in the official performance measure data, they really won't be included for the vast majority of measures. Okay. So next slide. Thanks everyone for using the chat. We'll keep trying that. So here's another data slide. In addition to looking at who Medicaid members are, we also began to ask questions about, one concept that's very important to the Medicaid transformation, which is the use of acute crisis-oriented care. So things like the emergency department or the hospital. So of course the emergency department and hospital have their uses. I'm a nurse, and having worked at Harborview, I can remember well the appropriate reasons for getting admitted to the hospital, but we also know that there's a lot of use of the healthcare system in inappropriate ways, and not for individual patients' fault or anything like that. It's just the way the system is structured, the fragmentation of care, both healthcare and social needs. So there's a lot of desire in this Medicaid transformation work and healthcare reform work overall to reduce use of expensive ED and inpatient services and shift that use towards more appropriate primary or preventive care services and social services as well. So with that in mind, one of the first things we've looked at with any of this claims data is emergency department visits. There's a lot of emergency department visits that happen, so there's a lot of data to look at, and they're a key measure of the Medicaid transformation. There's actually a performance measure, which is just ED use that cuts across every project that any of the ACHs could have chosen. So on the top here, we're looking at North Sound region. So there's all the zip codes that nest into the North Sound region. And what we're seeing there, the way that the zip codes are colored from blue to red is by the count of ED visits. Now, it's not just among everyone, though. What we actually did is we subsetted the population here to people who had 3 or more ED visits in a year. So these are individuals who are not like the average Medicaid member. They're using the emergency department a lot. Whether they chronically use it or whether they just had a bad year in this year that we're looking at the data. We're not showing that here, but this is a small subset of the entire Medicaid population in North Sound. So what we can see on the legend is that zip codes had anywhere from 16 emergency department visits all the way to 5,800. That zip code that's colored red there in sort of the lower center is in Everett. So a large urban center that happens to have a lot of people and thus a lot of ED visits, right? On the lower, though, we changed the scale. So on the top, we're just looking at the count of emergency department visits. And when we look at the counts of things, we're really working at an absolute scale, right? And so what matters is numbers. And so the underlying number of people who live in a region is really going to sway the colors of the map. On the lower map, we changed from an absolute to a relative scale. We're no longer looking at just counts of ED visits. We're looking at a rate. We're looking at rates of visits per 1,000 member months. And that's a really funky scale, and so I'm going to try to sort of walk through what that means. So what I want to do in order to do that is illustrate, there we go, illustrate one zip code that changed. And this is zip code 98257, LaConner. And what we can see on the top is that LaConner was colored blue. They had a very low count of ED visits. On the lower map, though, it actually is in the upper realm. As you can see, the legend ranges from 300 ED visits per 1,000 member months to 503. And LaConner comes in about 488, so they're very high up there. And the reason being here, oh, actually, no, I don't want to say this. I want to ask, why does this change? So why is LaConner colored blue, so having low count of ED visits on the upper, but colored red on the lower map? There we go. So someone already, another easy one. Great. Someone answered immediately. Small population, lots of visits. Right. So switching back and forth between sort of this absolute and relative scale is really helpful for doing place-based disparity work. Because the reason is that from a performance perspective, remember the ACH region is accountable to shifting the region level needle on these measures. So when you think about that, the absolute scale is really important. If I told you that North Sound, in order to hit 100% of its performance target for the ED measure, had to reduce ED use by 2,000 visits between 2017 and 2018, you naturally might think, okay, we need to look where the most ED visits are happening, right? So that's a matter of absolute. But if you ask the question, which areas or which racial ethnic groups are experiencing the most disproportionate amount of ED use, and what might that tell us about their access to primary care or their use of primary care? That's a totally different question. That's a question on the relative scale, and it invokes more of a sense of justice, right? Another thing that we've been doing. All right, and as you noted actually over here, I didn't circle this, but Everett has both a large absolute count of ED visits as well as a large rate. So they're not just showing up here because they're a large population of Medicaid members, they're also showing up here because there are members there that use a disproportionate amount of ED. Okay, next slide. So expanding on that concept of using the data to look at disparities at the population level, rather than defining populations by where people live or by race, we can also define or subset the Medicaid member population by health status. Here, we're not using APCD data. Here, we're actually using King County specific data. So this is not North Sound anymore. And the reason is because we're separating the King County Medicaid population into three groups based on the presence of chronic illness, behavioral health needs, or both. So the gray line on the bottom is the overall Medicaid population in King County. And what this is showing here is the same statistic we saw on the last slide, which is the rate of ED visits per member month. Oh, and I forgot to sort of break that measure down. So let's actually take an example. So on the lower left, you see that in 2014, the overall Medicaid population, King County, experienced 41.6 ED visits per 1,000 member months. What that means is if you were to follow 1,000 members, Medicaid members in King County over a month, they would have 41.6 ED visits, or to round to make it more logical, 42 ED visits. That's what the scale is meaning here. So on the lower in the gray, we have the overall Medicaid population. In the yellow, we have Medicaid members who have a chronic illness, and a long list of chronic illnesses we looked at: asthma, diabetes, variety of heart disease, hyperlipidemia, anemia, all sorts of things. In the blue, we have members with a behavioral health need only, so including things like depression, schizophrenia, anxiety, so on and so forth. In the green, we see the very small population of Medicaid members who have both a co-occurring behavioral health concern and a chronic illness. And my question for the audience is, why is there such a large difference between the blue line and the green line? I see one response from Crystal, HIPAA. Can you share more about what you mean by that? I'm not sure I understand. Okay, yep. More data coming in, or more questions, more answers coming in, sorry. So Crystal wrote more to clarify, and there's also a response from Monica I'll mention in a second. So Crystal commented that, asked rather, is the behavioral health data not being submitted? So thank you for asking that. I should have mentioned that. Now, the reason that I'm not showing you North Sound data here and showing you King County data instead is because we are using Medicaid data linked to our behavioral health organization data. And so we are actually looking at what is the most complete view of behavioral health needs and services that's possible for King County, I believe. So this does include publicly funded behavioral health services. Monica wrote lack of integrated care options. And then Karen just wrote chronic diseases are stressful. It can lead to behavioral health issues in addition to the integrated care issue. Great. So yeah, I mean it's a combination of things here, right? So we can see here in this line chart that having a chronic illness in yellow does increase your risk of having an emergency department visit for any reason. Having a behavioral health concern does as well, but having both together, that intersectionality, increases even more. And so what we're seeing here is that individuals with the most, and I'm sure you don't need me to tell you this, with the most complex health and social needs are the ones who are failed the most by our fragmented delivery of care, right? And so the lack of those integrated care options is going to come down most heavily on people who have the most complex needs, and thus would drive those individuals potentially to use services that are open always, right, and can't turn people away, like the emergency department. Okay, going on to the next slide. No question on this slide, just a sort of a quick sort of a display of an early attempt to look at cost of care. This was before the Medicare fee-for-service data was in there, which is why it's a little bit skewed towards younger populations. But here, this is just looking at all of the healthcare services that are in the APCD for the entire state, broken down by ACH region, as you see. And then it asks the question, what are the costs of care, the paid amounts for services by age groups? You can see the age groups on the lower. So in this particular slice, because we don't have a lot of older adults at the time this analysis was done, because Medicare fee-for-service wasn't in the database, we saw that there was more higher cost of care among middle-aged and older-age adults compared to children. This was just the tip of the iceberg, and we envision doing much more cost-related analyses as we move forward with this work. Okay. Again, no question on this slide. This is the final data slide, I believe. But this wanted to sort of end with some more North Sound specific data. So this is actually very recent stuff that we did, and this is looking at 2017 data. And we did this at the request of North Central ACH, but whenever we run the data for any ACH, we run it for the entire state if we can, because it's basically the same process for us, and it supports transparency and cross-shared learning. So here we have 4 chronic diseases. 3 of them are considered physical diseases, and 1 of them is a behavioral health concern, depression. On the upper left, we're looking at the percentage of people by zip code who have asthma in the past year. So this is looking at people with asthma in 2017. The zip code that's colored red, having the highest rate of asthma, diagnosis rate of asthma, is Lopez Island with 11.3%. Next to the right, we're looking at the same thing for diabetes. And we see that the zip code 98267, which is Marble Mount in the North Cascades, has the highest diabetes prevalence of 6.4%. On the lower left, we're looking at high blood pressure, hypertension. And 98253, which is the Greenbank area of Whidbey Island, has the highest hypertension prevalence rate of 14.3%. On the lower right, we're looking at depression. And 98225, which is Bellingham, has the highest depression rate, 21.9%. So this was interesting to me, and you know, I just prepared this just for this presentation, so I haven't had any opportunity to sort of ground truth this with North Sound or you all on the phone. But this is just sort of an example of what North Central was asked to look at, which is, you know, if we look at all the chronic diseases that we're interested in focusing on, because we know they're related to use of acute crisis-oriented services, we know that they're important from an equity perspective. How do we see prevalence across the North Central region, or in this case, I'm looking at the North Sound region. So just an example of how we can do place-based sort of disparity or difference work, as well as then look at how these differences change over time. Okay. Any questions on this before? There's only one more slide, so we can always come back to this. Let me just finish on this slide. So in terms of what we have ahead of us for next steps for this work, we envision a continued effort to assess the validity of this APCD data for behavioral health analysis. I'm not feeling too optimistic about it based on sort of provider organization level analysis we've been doing for North Central last week. But that just helps us, you know, it's helpful to have, it's really helpful, this is a lesson I learned really well also from talking with Urban Indian Health Institute about tribal data, is that it's really important to know the limitations to your data and to really educate government organizations and stakeholders about them, because that's the only way that things change. I see a question. Hold on, let me go back to the last slide. On the depression map, there's another red spot in Snohomish. Where is that? I don't know. I can't. Does anyone? You may know your region better than me. If no one knows and no one writes back in the chat, I'm happy to bring up the actual interactive version of this during the question period, and we can look at it together. Okay, I'm going to go back to this slide. Another area of work is developing a primary care visit definition, as well as a primary care provider definition, as well as a way to attribute patients to clinics. And the reason for all that is because the ACHs we serve want to know that. They don't only want to look at use of crisis-oriented services like the ED or the hospital, but they want to know the use of primary care. And the reason that's challenging is there's no nationally standardized or state standardized way for how to define a primary care visit or how to define a primary care provider. There's many definitions out there, and they all lead to different results. And so we're doing work, and we will be working with our ACH region partners as well as primary care organizations that volunteer to sort of ground truth some of this data to help move that work forward. We'll also be looking at leading causes of acute care utilization in ED hospital. What I showed you before was just all-cause use. And then doing more and more provider-level analysis, which we're just getting into right now, including ground truthing is the most important for us. If we produce provider organization level information like, here's how many people you serve, and it doesn't ring true for the providers that we work with, then we're not going to feel comfortable using this data for that use case. And then finally, we're also scoping out using this data for program evaluation, including evaluation of Pathways Hub or care coordination efforts in North Sound and North Central ACH regions. Okay, I'm going to stop now. That's the end of the presentation, and happy to take questions. I'll wait for a moment to see if there are any questions for a particular slide or anything like that. If not, I'm happy to bring up that interactive map from which I took the screenshots for this slide, so that we can answer the question about depression. All right. Not hearing any other questions. Let's look at depression. So I'm going to filter, and this is publicly available. We made this from North Central, but as I mentioned, all the regions are included. So I'm choosing North Sound. I'm on this 7-month cohort. So that's the cohort where we exclude members of 5 months or more of Medicare or commercial coverage, and I'm going to select depression. Let's see if we see what we saw before. Okay, good. So here we have 98225. That, I believe, looking at my notes, is the Bellingham zip code I mentioned. Over here, 98257. Hold on a second. I feel like I mentioned this on another slide. Oh, that's LaConner, right? And down here, 98201. Is that not? That's Everett, right? So we've got Bellingham, LaConner, Everett, and I don't know if we're over here. Oh, this is in the North Cascades, this area.
Thank you, Eli.
Sure.
Looks like we have one question.
Good question. Very keen eye. So the dark gray is the best we can do for coloring a zip code that has to be suppressed to protect individual confidentiality, and that's per our data use agreement with the All Payer Claims Database. Any zip code in this map that has fewer than 11 people has to be suppressed. And so this zip code over here in the North Cascades, as well as this one of the islands over here, is suppressed. The light gray back here is simply just, we're using Tableau, which is a software of how we make these interactive maps and can publish them online. This is just the color they use for the land beyond our area of focus right now. So if I chose the whole state, that would all go away, because then we would be looking at, actually it wouldn't go away, but everything now gray is outside of Washington State. So this is the entire state, but it's kind of hard to look at the entire state. I find it more useful to look at a given region or collection of regions. So you could look at North Sound and King together because they border each other, and that might be an interesting. Of course, then you don't see any red, right? Because you really have to zoom in over here to see. I'm not going to zoom in right now because it might be a little slow on the shared screen. There's areas of downtown Seattle that have where there's a large homeless population that have very high depression prevalence, is my guess. So let's see. So there's a question. Let me go back here. I think parts of Whatcom County are part of the light gray here. Does that mean there's no data for these areas? Good question. So there probably are, and maybe I missed one. Actually, let me look. So what's next to North? Let me add North Central here because this will space it out so we can see what's missing here. Yes, you're right. So these areas are data. They're zip codes that don't even exist in the database. I've gone through some of the maps I've made. I've gone through and added them. Some of these are national parks, state parks. Sometimes tribal reservations, tribal lands show up as gray because there is no data. When I do due diligence, I go through and make sure those all come up colored gray too, meaning suppressed because we don't have any data on them. But I may have not gotten to these zip codes right here. But yes, it does mean that there's no data on those areas. Thank you, Nat, for writing in. So most of that's national park, some of that is reservation land. Any other questions? And I'll share, since we've got the chat open right here, let me share just so you can have it in multiple ways, I'll share the link for this Tableau dashboard, as we call it, so that people can feel free to explore it, as well as the other tabs on their own.
All right, great. This was awesome. Thank you so much, Eli.
Yeah, of course. Thank you.
If there are not any other questions for Eli, I think we can switch screens now and just sort of summarize and let you know what's coming up next.
Okay, I stopped sharing.
Okay, I will try to share. Okay. So we're looking at our contact information. If you have any other questions for us or for Eli, if you would like us to relay any information or any details on how we are going to be using this data in our work, feel free to send us an email to team@northsoundach.org. Otherwise, I think the next upcoming webinars, this is a part of our weekly webinar series, and so the next one is going to be next Wednesday at 10 a.m. With Upstream. And then the 18th looks like we have one on HIPAA. And then our next data webinar, because the data webinars are always the last Wednesday of the month, is going to be on data sovereignty. If there aren't any other questions, it looks like NICA has posted the link to the evaluation in the chat box. So before you sort of sign off, please click on that link and fill out that evaluation. It's real helpful. Otherwise, I think we're going to sign off. Thank you so much, Eli, and thank you everyone for joining us today.
Thanks, everyone. Bye-bye.